Welcome back. Again, my name is Mark Silver. I'm presenting a series of videos to help explain as much as possible borderline personality disorder from my particular perspective, given my vantage as a forensic expert for many, many years, having done thousands of cases. The previous video, which is based on my book, is very much of an introduction. What I'd like to do now is break the present topic into two videos, and we're going to be talking about how to conceptualize the criteria of borderline personality disorder. I would start by saying that it's generally assumed that the various editions of the DSM are based on hardcore research. Research has obviously played a crucial role in developing diagnostic criteria and even new diagnoses. However, the reality is that politics has also played a role. For example, intellectual disability, which was formerly referred to as mental retardation, was changed in name because of the stigma. I'm hoping to keep politics out of this book that I've written, and hopefully to keep it out of the videos that I'm presenting. I'm not going to discuss what I believe are the merits or the drawbacks of the criteria of borderline personality disorder as outlined in the DSM-5. DSM is Diagnostic and Statistical Manual. There are clinicians who dismiss BPD as a disorder altogether. Other clinicians dismiss the DSM, present and past editions. They see it as just folly. And still others believe that persons diagnosed with BPD have been misdiagnosed so that a serious clinical error has occurred. As far as I'm concerned, what's most important is to focus on the human being whose presentation is often quite nuanced, and also to remember that a person can never be explained by research or clinical criteria alone, no matter how accurate they might be. It's my feeling that research without clinically informed empathy is simply misguided. Humans are dynamic and changing creatures, so criteria that seem applicable to the person at one point in his life may be completely inapplicable at another point. Indeed, a person may have the ability to abstain from impulsive behaviors all week, attending to daily matters in a responsible way, and yet reserve the weekends for sexual and spending impulsivity with little overt risk to the weekdays that follow. It is also very possible for two people to have BPD, and yet their symptoms may be quite different. So they experience the disorder in very dissimilar ways. It's necessary to evaluate and reevaluate not just particular symptoms, but also to consider when they appear, what they mean, and how the person functions in a particular context. The best way to understand a human being is through a clinical psychosocial evaluation, which is what we're going to talk about now for a few minutes. The psychosocial evaluation is a key strategic tool used by clinicians to elicit information to learn about people and conceptualize general functioning and mental health issues, revealing a host of details about the person's life. There are several foci in the evaluation, and I want to mention what they are. The first is childhood experiences, both subjective and objective experiences of the individual. Next, quality of relationships to family members, which is sometimes referred to as family dynamics, how people interact and relate to one another. The next important criteria in psychosocial evaluations is adult development. Development is a lifespan phenomenon that occurs throughout early and middle and late adulthood, geriatrics, and there are even stages of death. The next criteria, perception of self and other through experiences and interpersonal functioning. This is sometimes known as identity and self-esteem, as understood through object relations theory, which hopefully we'll get to discuss later in the videos. The next criterion understanding someone through psychosocial assessment is influences in the home, environment, within the person's culture, religion, and even their value system. Next, community interaction. That has to do with the person's education, employment, socialization, and interests. This is a very dynamic and changing area because, of course, a person, for example, in terms of education, may have very different educational experiences at different points of their development. Next is medical and psychiatric issues and pathology. And when I say medical and psychiatric, I don't just mean major medical or psychiatric issues that a person may encounter in their life, but also minor issues, issues that people may not necessarily see a physician for to ask about the issue. Next, stressors. This is a hugely important issue. Stressors can involve investigations regarding trauma, loss, shame, resentment, fear, anger, jealousy, guilt, and various challenges due to frustrations and disappointments that a person may encounter in his or her lifetime. Next, strengths and vulnerabilities. That is looking at the resilience and ego defenses of the person. To what degree is the person able to cope? To what degree is a person able to understand challenges and put them into proper perspective versus perhaps becoming overwhelmed by them? And the last major issue in the psychosocial evaluation is to look generally at the person's, their core needs, their hopes, their dreams, their sense of trust in others, their values, and what drives them, what motivates them. Although there are multiple other clinical considerations in psychosocial evaluations, ultimately it's the clinical psychosocial evaluation that does provide what is most important in understanding a person. And I say that because if you want to understand a person, you can talk to a person for weeks and months and years. I mean, look at people that write biographies, for example. Clinical work is very different. We have to be very narrow. We want to understand the first person very broadly. Don't misunderstand me. Well, we have to be narrow enough in our areas of investigation so that we're time sensitive, that we don't have 1,000 years to try and understand the person. And we want to understand the person from not just a very clinical perspective, but from a clinical psychosocial evaluation perspective. I want to give you some examples that I have in the book about why psychosocial evaluations are so important. Inadequate mothering may cause a young child to secrete more stress, that is cortisol hormones, into the bloodstream, creating an epigenetic change that is stable but potentially reversible alterations in a cell's genetic information that result in changes in gene expression but do not involve changes in the underlying DNA sequence. Conversely, anxious mothers in the third trimester may secrete more cortisol, which may lead to a more verbal toddler. However, with all this, blood and genetic testing will tell you nothing about the quality of mothering in the absence of a psychosocial evaluation. So all this talk about cortisol, schmortisol, of course it's important. We want to know hormone levels and so on if you're a physician. But the way you really understand how a new mother interacts with the child and how the child interacts with the mother has to do with a clinical psychosocial evaluation at its core. I'll give you another example. High levels of testosterone do not make people more aggressive. That's a myth. Rather, it makes them more sensitive to cues that trigger aggression. However, it's impossible to know what those cues are without a clear understanding of the kinds of interpersonal fears, relationships, and anxieties that the person harbors. Another example. It is true that oxycodone, which is made in the hypothalamus and controls trust and empathy, can make us more social towards people who are more like us, and less social toward those who are not like us, them. But it is impossible to understand us and them unless you do a clinical psychosocial evaluation, unless you really get at the person's likes and dislikes, perceptions of self and other. Another example. A child's brain circuitry, including neurons, which is the gray matter, and synapses, which is the connections between the neurons, the child's brain circuitry greatly increase in the cerebral cortex and are then gradually pruned throughout adolescence. The insulating myelin on nerve fibers that carry signals between nerve cells continue to accumulate gradually improving neural communication, and the adolescent's brain can become dopamine rich. Yet these changes in brain circuitry yield little or no clinical information about the adolescent's daily decision making and coping mechanisms in the absence of a good clinical psychosocial evaluation. Yet another example. The insular cortex may cause us to react with moral judgment, but that can only be understood in the context of a particular person's childhood, culture, or religious value system, which is understood through a psychosocial evaluation. Another example. The hypothalamus links the nervous and endocrine systems via the pituitary gland and may help coordinate autonomic nervous system functioning, controlling hunger, body temperature, and other homeostatic symptoms. But these systems exist in a particular environment where the person has particular environmental experiences, and understanding those particular environmental experiences for that particular individual, again, can only be understood through a psychosocial evaluation. I'm not a brain expert. I'm not a neurologist. I'm not a neuropsychologist by any means. And it's interesting. I'll just take it as an aside. I spent some time about 2 years ago really studying the brain. And it was absolutely fascinating. But what I found was that clinically, in terms of undertaking psychosocial evaluations, it doesn't really matter. It matters in some ways. Obviously, you have a serious brain injury. You obviously want your doctor should know where to intervene. If you have a brain bleed, you have to know specifically where in the brain it is to cauterize it. If you've had a specific brain injury that results in a very specific pathology, such as impaired vision, you want to know where that injury was. It's probably at the back, at the occiput. However, from a clinical day-to-day investigation into any particular person's development in life, understanding the brain has very limited feedback for us clinically without a clear psychosocial evaluation with the criteria that I went over before. Although the psychosocial evaluation remains the gold standard, there are alternatives. In particular, psychologists utilize a variety of psychological tests, most of which are self-report instruments, which ask clients to provide information about their health and well-being. It should be noted that the majority of psychiatric diagnoses are rendered in the absence of testing. The study of genetics, neuroimaging, and neurophysiology all have merit and can be highly informative, but we humanize the individual and we understand his decisions and behaviors, emotion, thinking, environment, culture, and family experiences through a detailed clinical psychosocial evaluation. Absolutely no medical or psychological test can replace the simple question, how do you feel? There's one major clinical limitation to the psychosocial evaluation. The clinician can only elicit information that the client is aware of. For example, I was once at a holiday party and saw a single mom leave early with her boyfriend, leaving her young daughter alone and frightened. The daughter became quite panicky, and indeed considerable support from her older sibling was needed. It's possible that when evaluating the daughter, when she is an adult, that she will have no memory of this event, and thus she may not provide a reliable history about the quality of maternal care that she received. Often, the quality of the psychosocial evaluation can be much improved through a parallel history, that is, by eliciting information from the client's family members. Because memory is selective and unreliable, it will always prohibit the person from providing a truly complete psychosocial history. As a result, while psychosocial evaluations aim for exactness, they often settle for approximation. I want to talk a little bit now about the secret of good clinical know-how. There is a secret to all good clinical understanding, and it is this: assign clinically significant meaning to seemingly unimportant behavior, emotion, and thinking. That is, the clinician's job is to observe and listen to the person very carefully without judgment and understand that a person's behavior, emotion, and thinking is not just a superficial presentation, but rather communicate or reflect idiosyncratic meaning that provides clinical insight into the person's psychosocial well-being and even psychopathology. Emotions or feelings aren't necessarily caused by overt thoughts, but are constantly foisted upon us by our subconscious based on former experience and how we perceive our environment. We then rationalize the choices that emerge from those emotions and feelings, often turning them into self-fulfilling prophecies. As such, we use emotional reasoning as evidence that something is true. Here's a personal example. I was walking with my daughter and struck my finger. Over the next several days, the finger became extremely sore with what seemed like pus inside. Weirdly, there was a dark spot in the middle of the injury. I was concerned that when I struck my finger, I got something inside it, such as a very small piece of wood which caused an infection and therefore inflammation. I saw several healthcare professionals, including a dermatologist, explaining what occurred. The problem was repeatedly misdiagnosed. It turned out that it was a wart, which is a small fleshy bump on the skin or mucous membrane caused by the human papilloma virus. Many skin warts contain one or more black dots near the center, which are in fact visible blood vessels that supply the wart with nutrients and oxygen. A good clinician should have noted the black dot in the middle of the injury and assigned clinical meaning to it. Clearly, it had to be something, and understanding what that something was would provide the key to a relatively simple diagnosis, repeatedly missed because the healthcare professionals ignored what was dead center in the injured finger. Here's another example. In my second internship in day hospital psychiatry, there was a patient who attended group therapy who would act with subtle moments of impulsivity, such as touching the ID badge of staff members. This was done without animus, aggression, or any other accompanying issue. My supervisor noted that this person could have borderline personality disorder. I was completely oblivious to this and skeptical about the supervisor's diagnostic ability, given such little information. It turned out the supervisor was correct. It was a crucial lesson about how understanding people based on subtle behaviors, but also how a clinician can extrapolate from a seemingly benign action to consider the possibility of more serious problems. This is not to suggest that every behavior, emotion, and thought belies a symptom of psychopathology, but rather that behavior, emotion, and thinking have a particular meaning to a particular individual given his particular psychosocial history. For example, fidgeting can have multiple meanings depending on who does the fidgeting and even when and where it occurs. For one person, fidgeting may signify he has a secret that he wants to share, but he is reluctant to speak about the matter because it's shameful. For another person, fidgeting may reflect acute anxiety because it is the first time he has ever spoken with a therapist. For another person fidgeting, it may indicate that he is lying about something. For another person, fidgeting may indicate a neurological symptom. Moreover, sometimes the reason for behaviors like fidgeting may remain unknown even after an exhaustive psychosocial evaluation is undertaken. For this reason, the best clinicians are both clinically astute in trying to understand the meaning behind a person's behavior, emotion, and thinking, and also humble, appreciative of our limits in understanding the human condition. I want to talk a little bit about DSM-5 definitions and patterns. According to the DSM-5, a personality disorder is an enduring pattern of inner experience and behavior that deviates from the norm of the person's culture. The pattern is seen in two or more of the following areas: cognition, affect, or interpersonal functioning or impulse control. The enduring pattern is inflexible and pervasive across a broad range of personal and social situations. It typically leads to significant distress or impairment in social, work, or other areas of functioning. The pattern is stable and of long duration, and its onset can be traced back to early adulthood or adolescence. Excuse me. The personality disorder subtypes are paranoid, schizoid, schizotypal, antisocial, borderline, histrionic, narcissistic, avoidant, dependent, and obsessive compulsive. This is a verbatim definition of personality disorder, and yet, if the definition is so clear and encompassing, why are clinicians so easily misled into misdiagnosis, and how are people with borderline personality disorder unable to recognize that they clearly have a psychological or mental health problem? While symptoms are important, the key word here is pattern. Excuse me. Pattern is an important concept because it is crucial to recognize specific behavior, emotion, and thinking that exists or repeats over a long period of time, so that pathology is indeed recognized in the context of a person's overall functioning. Obviously, pathology can also occur in acute forms. For example, someone can experience reactive psychological trauma or even psychosis after experiencing a sexual assault. At other times, however, pathology is not recognized, and so patterns are not recognizable even over long periods of time. For example, a person can have a serious medical issue, but because symptoms do not manifest in an overt way, or perhaps because the person's functioning is not altered, symptoms may be hidden and making a diagnosis becomes impossible. The consideration of patterns may also help guard against the danger of overdiagnosis and misdiagnosis, which can lead to debilitating stigma and bias. When the reason or causation for disorder or disease is absent, patterns of functioning must be considered carefully as a means to understand and help the person. The last thing I want to talk about today concerns BPD as a disorder. Borderline personality disorder is a disorder. It can be referred to as a disease, and therefore it is a very serious matter, like any medical illness. Disease and disorder are more or less synonymous. However, disability specifically means that the person is not able to function in a normal way versus disease. BPD undoubtedly has a genetic component. However, there are so many genes at play that there are no specific biological markers, as far as I know. In general, there may be dozens of genes that contribute in different ways to disease processes. I use the word disease purposely, as anyone with BPD will tell you, it is truly an affliction. Disease means pathology, and disorder is a close synonym. My computer tells me that disease is defined as a disorder or structure or function of the human, animal, or plant, especially one that produces specific signs or symptoms or that affects a specific location and is not simply a direct result of a physical injury. This definition fits BPD quite well, especially as there are recognizable patterns of behavior, emotion, and thought that characterize the person at the individual level and also as a category of disease. Still, the goal is to humanize the person and not label or pathologize the person. Medical pathology is based on empirically physical observable problems with cells and tissues, even at the genetic level. Mental health is different. Nothing can be placed under a microscope or scanned or examined to diagnose a mental health problem, except for a post-mortem brain tissue examination that may reveal Alzheimer's disease. Some people conceptualize BPD as having stereotypes in which the person's presentation satisfies the general definition of the disorder, but with specific prominent issues such as impulsivity. BPD can also be conceptualized on a spectrum of criteria and seriousness, much as autism has been reconceptualized as autism spectrum disorder. While this may detract from the specificity of clinical description, it allows for a broader range of symptoms in the area of behavior, emotion, and thought. BPD is also a syndrome because it is understood empirically by various criteria and symptoms which, taken together, provide a consistent and general recognizable clinical presentation. Although I'm a firm believer that understanding how a person generally functions is just as important as understanding specific pathology, and indeed they are inextricably related, there are moments when exact information is required. For example, when someone overdoses and seeks emergency room help, the healthcare worker needs to know exactly what drug caused the overdose to know what, if any, treatment should be administered. Borderlines are sometimes dismissed without sympathy as they are seen as vying for attention through erratic behavior and unstable moods. However, if the person who presented in this way suffered a catastrophic back injury as a child from an automobile accident, the person would gain sympathy for the rest of his life. Similarly, I've seen many children with ADHD, and often parents or even professionals will say things like, "Why can't the child just focus?" Or, "Why can't the child just sit up straight and do his homework and pay attention like everybody else?" However, when the child has difficulty with focus, homework, general assignments, socialization because of congenital deafness, the child receives endless empathy. Borderline personality disorder is a disorder or a disease, and persons who suffer from borderline personality disorder must be afforded sympathy and understanding due to their challenges, deficits, and even disabilities, some of which may be lifelong.